On behalf of HealthCert Education, I'd like to welcome you to this evening's webinar. This is the fourth webinar in a series aimed at bringing value to our alumni by providing clinical guideline updates and new information to you easily and concisely with a wonderful presenter who shares relatable and interesting cases. Tonight's webinar focuses on clinical guidelines updates for the management of type 2 diabetes mellitus, key changes and practical applications. Now, before we get started, I'll just run through some housekeeping and instructions. At the end of the webinar, we have a post-webinar survey that provides you with the opportunity to give feedback on the webinar and request some more information on any of our courses that might help you in your CPD journey, or to subspecialise in particular areas of interest for your practice. For those of you attending live or watching the recording, you may be able to apply for CPD for this webinar. So a certificate of attendance will be emailed out along with the recording with some instructions on how to self-submit to your relevant college for consideration of CPD. Now, with that, let me make a proper introduction to Dr. Simone Gonzo. Dr. Gonzo began working in healthcare as a registered nurse in hospitals throughout Queensland in 2003. After making the change to medicine, she graduated with an MBBS from the University of Queensland in 2010 and gained her fellowship with the RACGP in 2015. Dr. Gonzo enjoys all aspects of general practice, including family health, mental health, chronic disease management, and complex primary care. She also has a special interest in teaching and training GP registrars and medical students and running webinars such as this. Dr. Gonzo is a champion of general practice and promotes the importance of this specialty in the healthcare landscape. She's currently working on a Master of Healthcare Leadership. And with that, I'll ask Dr. Gonzo to take the floor. Dr. Gonzo, over to you.
Thanks, Campbell, for that glowing introduction. Yes, I thank HealthCert for our sponsorship tonight. So another important clinical guideline we'll be looking at for something that we commonly see in general practice. So it's the management of type 2 diabetes mellitus. First up, we'll just do our acknowledgement of country. So I'm in Caboolture, which is Gubbi Gubbi country, and paying our respects to elders past and present. And that's just our little introduction that Campbell's done. So our learning outcomes for this evening is that we'll be determining the content of the updated clinical guideline and applying that guideline to patient cases. And I'd ask you just to think about patients as we go through, work through the information and just see what might apply and what might, be of interest when you're dealing with those interesting diabetic patients. So when we look at where we are at the moment, on the left is our new Management of Type 2 Diabetes Handbook for General Practice. 2024, it was published 326 pages compared to the previous one on the right in 2020, which was 198 pages. So you can see the developments that have gone on in that time, and it's just so valuable for HealthCert to be able to give us this opportunity to summarize all of those changes and keep abreast of what's happening in general practice. So the topics that are new in this handbook is we're discussing remission of type 2 diabetes, weight management interventions, sleep and diabetes, disability, dementia, and cognitive decline and hearing impairment. There's also significant updates to existing sections. So they're listed through there, and we'll touch on all of them. It's quite a contemporary update that they have presented to us in this latest handbook, and it's very broad as well in terms of age groups and travel, surgery, things like that patients build into their daily life. So moving on to our new topics. Remission of type 2 diabetes. So lifestyle changes, mainly weight loss, may be able to achieve diabetes remission. That is not a cure for diabetes. So it's defined as a HbA1c below 6.5% for at least 3 months without any glucose lowering medications. So our diabetic patient has no medications for 3 months, maintaining their HbA1c below 6.5%. Bariatric surgery can be used to potentially induce type 2 diabetes remission. And as I've already mentioned, remission does not mean that it's cured or reversed. If we do manage to achieve remission, the criteria is that we would be performing regular measurements at a minimum interval of every 6 months, just to assess the persistence of diabetes remission and or relapse of diabetes. So especially when this is so dependent on lifestyle changes, it's really important to not forget to do those checks every 6 months to make sure that we're keeping an eye on that glucose control. In overweight or obese diabetics, we really need to look at diet, and we need to be encouraging exercise. These are the weight management interventions that are key in terms of managing diabetes. They form the basic foundation of any diabetic management plan for any patient, regardless of their age, their ability. Exercise programs can be so varied, so long as the patient is moving in some sort of fashion. Obviously, younger, more active people can get more cardiovascular exercise, but we need to also really emphasize the diet and exercise as being a key contributor to managing our weight for diabetics. Obviously, we've got a new range of pharmacotherapy that can help with obesity, and they also should be considered for people with diabetes and overweight or obesity, along with these lifestyle changes. So it's becoming more apparent that we're not waiting to use that obesity pharmacotherapy until a last resort. We're introducing them very, very early on, especially with the younger population. So people who achieve weight loss goals should be offered long-term weight maintenance support, which should at a minimum include monthly contact, ongoing monitoring, self-monitoring of weight, and regular physical activity. When I was putting this together, I was thinking about how achievable it is to manage a patient on a monthly basis. For most of us, probably not, unless they're that elderly patient that is, coming for a few different reasons. But I think when you do see a diabetic patient, weight, blood pressure, the basic measurements should always be done, just so that we can manage that. Even if we're seeing them at 3 months or 6 months, it's good to always just manage their weight to see a trend, for that accountability for the patient, so that they can self-correct and see if they're actually doing their activity and if they need to rein in the diet a little bit more. So where does metabolic surgery fit in? As a weight and glycemic management approach in people with type 2 diabetes with a BMI over 30. If they're otherwise good surgical candidates, yes, by all means. That is not offered in Queensland anyway, in the public realm, very readily. Privately, it's much more manageable and achievable to have your metabolic surgery done. And the other group, people with type 2 diabetes and a BMI of 30 to 34, if their hypoglycemia is inadequately managed despite optimal treatment. So those patients should be considered for metabolic surgery as a weight management intervention for their diabetes. So medications associated with weight gain, we have the usual suspects there. So top of the list, as the paradox, is insulin, sulfonylureas, working down to our antipsychotics, the TCAs, the tricyclic antidepressants, lithium, and down the bottom is glucocorticosteroids, so prednisone. They're the ones that give us that challenge when we're trying to manage a patient's weight. Sleep and diabetes. This is a new topic that was included in the handbook in this latest edition. And the recommendation is that we consider screening for sleep health in people with diabetes, including symptoms of sleep disorders. So that's your sleep apnea, snoring, feeling tired, the Epworth Sleepiness Scale, disruptions to sleep due to diabetic symptoms, nocturia, or management needs, and worries about sleep. So if any of those are present in our patient, the recommendation is that we refer to sleep medicine specialists And as a minimum, you would probably be doing if you meet the criteria for it, a home-based bulk build sleep study to at least exclude obstructive sleep apnea in those patients. Disability and dementia and cognitive functioning. It was interesting to read how we need to be looking at this in adults basically who are over 65 at the initial visit annually and as appropriate. So we're looking for early detection of mild cognitive impairment or dementia, and that could be done just as a quick MMSE. It's easier to do in the population that's over 75 because you can build that into their annual health assessment with your practice nurse, asking your practice nurse to do the MMSE. And it's not a bad idea to do that yearly anyway, just to see if there is a baseline or a threshold or something developing. If we are developing cognitive symptoms, we want to really simplify the diabetic treatment plan as much as possible. This needs to be something that the patient can live with and build into their lifestyle rather than being a cumbersome burden that they can't feel that they can handle, and therefore they sort of abandon it, and we back to where we started. So that basically rounds out our new topics. We'll go into more detail in terms of where they fit into the significant updates, and we'll touch on those as well. So with early onset type 2 diabetes, so this is people aged 18 to 30 years. Now, due to the complexity and management and higher risk of their complications, it's recommended these patients are referred to an endocrinologist. I'm not sure how practical that would be in certain demographic populations with regards to a possible shortage of endocrinologists and the prevalence of diabetes in that age group. If it's a female who's looking to having their families and they're in antenatal care, they often have access to more diabetic attention and care. However, the males do tend to be left behind a little bit in this age group. So we'd want to be really mindful of that in our screening, and also getting them off to an endocrinologist so that they can appreciate the severity and the long-term complications that we're trying to manage. So what do we start a person on when we diagnose them with diabetes? So we're looking at a person-centered approach and to guide us in terms of our medication and regime. We need to look at the patient's comorbidities, their hypoglycemic risk, the impact on their weight, the cost, side effects, and just their lifestyle. What's going to be easier for them or their carer to be able to manage with their lifestyle. So we're also looking at healthy behavior interventions, which is what we've discussed about exercising and diet or movement and healthy choices of meals. And if those glycemic targets aren't achieved within 3 months using the healthy behavior interventions alone, then we'll be instituting our anti-hyperglycemic therapy or medications to ramp up our control and reduce the risk of microvascular complications. So what would we be using as a first choice for patients with diabetes? Metformin is always at the top of the list. So unless there is a reason why the patient would not be a good candidate to be using metformin, we'll be going with metformin to see how they tolerate it, how they respond to it as well. So there is no set dose for metformin. We usually start low and go slow. It's an excellent medication because we have so much long-term experience with it. It's old, reasonably cheap. We know how it works, and it's good. Sometimes we just need the metformin. Nice 1 tablet a day, twice a day if we need to. Comes in lots of different formulations as well. If a patient presents with metabolic decompensation, for example, they are marked hypoglycemia, sometimes they may need to be considering insulin before to correct that insulin deficiency before we move on to oral medications. So this is more realistically done in a hospital setting. However, the patient may be discharged from hospital into our care on insulin, and we can therefore from there we can take it on and see how they go, and perhaps wind that insulin back and get them just on metformin or other orals, so that one, they don't have to do their injections, and two, they can avoid the weight gain that's associated with the insulin. So advancing treatment, what do we do when we're finding that we're not getting our agreed targets with our initial dose of metformin? So we monitor our HbA1c at 3 to 6 months, depending on the patient engagement, what's easier for them. If they're not achieved, we look at other classes of glucose lowering agents and what we're going to do to optimize that control. So I'm sure you've all seen before our very busy schedule, which is the National Diabetic Support Services glycemic management algorithm. And you'll see from that one, we'll briefly talk about just the 3 tiers on there. Monotherapy, we initially start at the top, metformin. We can also start with our insulin, sulfonylureas, just depending on what's the best choice for the patient. We quickly dip down into our dual therapy, and that basically could be anything that we think may suit the patient, depending on their lifestyle, what works for them, comorbidities. So it's still a very useful document, and especially in terms of just reminding ourselves what is available for those patients. Now, the next topic in the handbook was use of technology in managing our type 2 diabetics. The handbook recommends that continuous glucose monitoring be considered for continual or intermittent use in all individuals on intensive insulin therapy. However, my understanding is that it's only available for type 1 diabetics and pregnant type 2 patients funded. So unless the patient has private healthcare or wants to fund a CGM themselves, which is the Libra, that the sensor that they wear and that is tracked to their phone, which are a fantastic tool for patients to monitor their glucose. They're a really useful tool for patients. However, as I said, they're only for or funded for type 1 diabetics and pregnant type 2 patients in Queensland anyway. So when we look at cardiovascular risk, the recommendation is that we're calculating cardiovascular disease risk level using the Australian Cardiovascular Disease Risk Calculator, which I'm sure you're all familiar with, the websites there. Age ranges for assessing it without known cardiovascular disease is basically all people aged 45 to 70, large range. Diabetics aged 35 to 70. So that would probably, in my mind, I basically assess all diabetics with their cardiovascular disease anyway, and we'll get to the things that we assess them on as we move through. And also our ATSI patients, assessing them even younger from 18 to 29, and from there on up, we're looking at what their cardiovascular disease risk factors are. So that's just a prompt letting us know that's our quick CVD check calculator that you can access online for free. And that then breaks down our cardiovascular risk into tiers of high, intermediate, or low. The calculator gives you a risk on that depending on their smoking status, their age, their HbA1c. There's a few other indicators built into that, which is probably another webinar, another talk in itself. However, it's good just to realise or understand those things that determine those risks. But most diabetics would be falling into the intermediate to high risk, because you can see even at, from 5% on basically puts you intermediate to high. So it doesn't take much for these patients to end up being considered a cardiovascular disease risk, which is one of the issues with diabetes inherently. So for ATSI people, we're reminded to reclassify this population's estimated CVD risk to a higher risk category after assessing their clinical, psychological socioeconomical circumstance and community prevalence as well. So in more remote communities, which possibly have a higher CVD risk, we would be classifying them to a higher risk category. So the theory is if in doubt or borderline, always play it safe and classify that patient into a higher risk category. And that will mean that we're looking at much tighter controls and targets for them. So in people whose estimated risk is close to the threshold, once again, the recommendation is to consider reclassifying them higher. And the particular populations mentioned in this new guideline edition are the Maori people, Pacific Islanders, people of South Asian ethnicity, and also people with pre-existing cardiovascular disease are at a high risk of another event. So we need to be really super careful with this population and anyone who's had previous history, that we really want to make sure we manage that risk. How do we manage that risk? So for people at a high risk of cardiovascular disease, which is the greater than 10% cohort, we're wanting to manage their lipids, their blood pressure, and have them on medications pretty much right from the beginning, so that we can manage those targets. We need to encourage the patient or educate the patient so that they understand the benefits and harms, and also so that we can get them on board in terms of their shared decision making, so that they can understand what our goal is for them. And as we've already covered, the encouraging, supporting the healthy lifestyle. So that once again is no smoking, minimal alcohol, exercise, and healthy choices, healthy meal choices. So in adults with type 2 diabetes who have cardiovascular disease, multiple cardiovascular risk factors, and or kidney disease, so we're now ramping up our comorbidities on this population, the recommendations are that we introduce early our sodium glucose co-transporter, so empagliflozin, dapagliflozin, or a GLP-1 RA, so semaglutide, to other, and so we're recommending that to the other glucose lowering medications. So we still keep them on metformin, and we just add these other medications in to really manage our CVD risk. The multiple cardiovascular risk factors, in a nutshell, what we were sort of introducing before is men over 55 years or women over 60 with diabetes who have one or more additional traditional risk factors. So they're the usual suspects: hypertension, dyslipidemia, or smoking. So if the patient unfortunately ticks all of those boxes, we need to really aggressively manage all of their indicators. And yeah, we'll work through those with our case study, and we'll see how we manage and tick off all of those. So first up would be looking at hypertension. So antihypertensive therapy strongly recommended in patients with diabetes and systolic blood pressure over 140. So our blood pressure targets need to be individualized, and obviously through that shared decision-making process, weighing up the adverse effects and individual preferences, and basically really trying to target that down to 120 on 60, which is where we'll work through later at looking at our targets. So, and which one do we choose? Any of the first line antihypertensive drugs that effectively lower the blood pressure. I've also included in here this may be familiar to some of you. So this is the hypertension guidelines. You can see from that first drug choice, particularly useful in diabetics and or lipid abnormalities. On the left is our ACE inhibitors or ARBs, and a calcium channel blocker as a second drug. But mainly we can stick around this territory and manage the patient there for their blood pressure. So patients with diabetes, hypertension, chronic kidney disease, and or comorbidities of heart disease, the target we're looking at is less than 140 on 90. There is some dialogue in the literature saying that we need to keep that even tighter at 120 on 60 to 80. Obviously, the closer we can get to that, the better. Over 140 would be considered not well controlled at all, and that would still be putting the patient in in a bit of a dangerous situation. And once again, patients with hypertension and a history of TIA or stroke, they're also recommended to be under 140 on 90. So moving through to lipid-lowering medications, patients with type 2 diabetes and known prior cardiovascular disease would probably already be on a statin medication, irrespective of their lipid levels. So, except in the case of hemorrhagic stroke, and we'd be also looking to commence fibrates in addition to a statin when the fasting glycerides are greater than 2.3 or the HDL is low. So the idea with these medications so far with the lipids and with the blood pressure medications is that we titrate these up as high as the patient can tolerate so that we can achieve that really tight control for them. Diabetes is a lifetime condition, so we really want to ensure that we optimize their therapy early on. So in individuals with, this is a bit of a busy slide, but in individuals with atherosclerotic cardiovascular disease or other cardiovascular risk factors, but elevated triglycerides, it's recommended now that we add in icosapent ethyl, which is known as Vazkepa. That's one of the newer medications and probably would be introduced by a specialist in this area anyway. It's not something that GPs would initiate. For people with diabetes and atherosclerotic cardiovascular disease, treatment with high-intensity statin therapy is recommended. So it goes back to that previous theory of as high as the patient can tolerate. And also, you may have seen some patients that are now coming back from their specialists on a PCSK9, which is also known as Repatha. That's one of the injectables. And that's added to ezetimibe if the patient is not able to tolerate their statin therapy. Now, antithrombotic medication for patients that have known prior CVD and diabetes, these patients should receive long-term antiplatelet therapy unless there's a clear contraindication. The recommendation is aspirin therapy as a secondary prevention strategy in those with diabetes. Now that's based on a clinical history of atherosclerotic disease, not just imaging retinopathy risk reduction. Individuals who have documented aspirin allergy, we should be putting them onto some clopidogrel at 75 milligrams a day. In the guideline, we've got significant sections on diabetic eye-related diseases. So for individuals with diabetes, type 2 diabetes, they should be screened and evaluated for retinopathy at the time of diagnosis. This can be one of the things that is overlooked. There's a lot of things to go through and a lot of information for a patient to comprehend when they're first diagnosed with their diabetes. And often these are the things that get forgotten, but as you see them at their 3 monthly, 6 monthly, we can always just pick it up then. It's recommended that we follow up screening for people with retinopathy tailored to the severity of their retinopathy. And the recommended interval for those with no or minimal retinopathy is 1 to 2 years. So a good guideline is for your diabetic patients to just have an optometrist review every year anyway, and that way they can have in Queensland anyway, you can have a bulk billed optometry exam done yearly. That can include a retinopathy check as well. Examine higher risk patients who do not have diabetic retinopathy at least annually. So that's a good catch-all just to remember to do those patients annually. High risk is defined as patients with a longer duration of diabetes, suboptimal glycemic management, so difficult to control diabetics with hypertension or cholesterol problems as well. Also, people from cross-cultural, linguistically diverse backgrounds would benefit from a higher monitoring of their vision. So we're looking to conduct annual diabetic retinopathy screening for ATSI people as well, and also to delay onset and progression of diabetic retinopathy. Patients should be offered pharmacologically and non-pharmacological management options to achieve our glucose control, blood pressure control, and also our cholesterol control. That all helps to reduce the risk of retinopathy. Fenofibrate, in addition to statin therapy, can be used to slow the progression of established retinopathy. We'd be referring individuals with any level of diabetic macular edema or moderate or worse non-proliferative diabetic retinopathy to an ophthalmologist. Often what we'd find here in Australia is the optometrist can refer directly to an ophthalmologist, privately anyway. Publicly, the optometrist would refer to the ophthalmologist or to us, and we would put their letters with the optometrist with our referral, send that into the public hospital and get the ophthalmologist to have a look at the patient. It's still a good idea if the patient is seeing ophthalmology to also still have their annual optometry review as well. It's handy for them to have a regular optometrist just in case something does start to go a little bit pear-shaped within their vision, because the optometrist can quickly review them and then escalate anything that we need to an ophthalmologist. So with rapid and marked reductions in HbA1c, that can result with worsening diabetic retinopathy and should be avoided. Now that can be if we're talking about the population of the pregnant diabetic or diabetes diagnosed in early pregnancy. If we manage to improve that patient's glycemic management with antenatal clinic, that can give us marked reductions, and that can be a transitory worsening of diabetic retinopathy, bariatric surgery, or intensified insulin treatment. So as well as trying to get that glucose under control, we need to be mindful of that damage that may be done to the vision. So we'd be getting the optometrist to have a look at that as well. Interestingly, semaglutide or Ozempic hasn't missed out with the vision as well. So it's been associated with an increased risk of non-arteritic anterior ischemic optic neuropathy in an observational study. So, and this condition can occur independently of diabetes. So this is something that we may see more of as we use more of the semaglutide within the general population. It hasn't really made an impact as yet, but it's just something to be aware of with that patient who's starting the semaglutide, is still to get them to have the regular optometrist reviews. So chronic kidney disease in diabetics, we're looking to annually assess our urine albumin to creatinine ratio. So that's our spot ACR and estimated EGFR. I'm sure you're all aware of doing that with your regular checks. Regardless of treatment, we want to keep a very close eye on trends and baselines of what's happening with the kidneys. Treatment of hypertension should include drug classes demonstrated to reduce cardiovascular events. So that leads us back to that initial chart that we had with our list of hypertensive medications and the ones that are best used for diabetics. And that's our ACE inhibitors or ARBs. They're our recommended first-line therapy for hypertension in people with diabetes and coronary artery disease. Multiple drug therapy is generally required to achieve blood pressure targets, so don't be shy to add another agent in earlier. So it's not necessary to max out the dose of your initial ACE. You can also add in your calcium channel blocker, some amlodipine, something like that, if you find that we're not really managing the blood pressure with our ACE or ARB. Also, if the patient is unable to tolerate higher doses of their ACE or ARB, we can also add in a calcium channel blocker with that as well. So these medications need to be titrated to the highest dose that's tolerated, and we sort of walk that up, but we don't need to wait. If we're struggling to manage to achieve that, we can add another medication in while we maximize the dose on both of them at the same time, depending on the patient's side effects. So dapagliflozin is recommended to be added to other glucose lowering medications as well in patients with diabetes and chronic kidney disease. And we'd also be recommending semaglutide if the patient is unable to be prescribed dapagliflozin due to either intolerance or contraindication. Now, interestingly, the evidence base for this recommendation includes people with a eGFR down to greater than 30. So that widens the whole population that we can use these medications on, so that we can manage glucose as well as blood pressure and kidney disease. So with albuminuria, that's treated with the maximum tolerated doses of ACE or ARB. We'd be adding in finerenone, which that's recommended to improve cardiovascular outcomes and reduce the risk of CKD progression. So it seems to be a whole new range of medications that we would be introducing to patients with chronic kidney disease, or getting more comfortable, familiar with, using the dapagliflozin, finerenone, which is a non-steroidal mineral or corticoid receptor antagonist, similar to spironolactone, but we can use that with patients with an eGFR greater than 25. So you'll probably see patients coming back from the endocrinologist with a wider array of these medications, and we'll, as GPs, we'll get more comfortable using them, more familiar with using them as well. So interestingly, mental health was already existing in the handbook. However, it's in the previous handbook. However, it's had a huge expansion, and there's been a few different things that have come out of that. One of them is to routinely monitor people with diabetes for diabetes distress. So that is now a clinically recognized emotional response to living with diabetes and the medical, financial, and social impacts of diabetes. We'd be considering assessment of symptoms of diabetic distress, depression, anxiety, disordered eating, cognitive capacities, and also the caregivers and family members in the assessment is also recommended. So it's a condition distinct from other psychological disorders, estimated to affect 18 to 45% of people with type 2 diabetes. So significant amount of people, and severe diabetic distress is experienced by 20% of people with insulin-treated diabetics. So, and although these symptoms often overlap with depressive symptoms, it is considered a separate psychological condition that should be assessed for separately. It's important because it's associated with suboptimal self-care and glycemic outcomes. So the handbook does outline some tools to assess diabetes distress. We haven't gone into much detail tonight, but it's just an awareness of this is what to look for. And you may find that patients' personality or the way they view things starts to change, and it's very overwhelming to be diagnosed with diabetes. But this gives us an idea of how to manage it, how to look for it, and then what we do with it. So what we do with it is refer to our friendly mental health professional. So our psychologist should be able to help us via a GP mental health care plan. We're looking to manage the significant distress related to diabetic management, and also we're looking to manage fear of hypoglycemia, psychological insulin resistance. So what psychological insulin resistance is, a patient is advised to start insulin but can't get their head around it. So we need to get them comfortable with the idea of using injections, managing insulin, and to manage their chronic disease. And also other psychiatric disorders such as depression, anxiety, eating disorders, that all of those patients with type 2 diabetes should be referred to a psychologist so that we can start some work on how we manage this lifestyle change. The 7A's model has been recommended as a practical way to structure mental health care for people with diabetes. So we use that with a lot of different situations, but basically just being aware that people with diabetes can have these problems. We think it's bread and butter, but to an individual walking into our office, this could be a life-changing diagnosis for them. Ask about the problems, assessing for emotional problems using the validated tools, and also then advising patients about the problems, assisting them to develop a plan, and then referring them off through Assign and arranging follow-up. So that's our 7A's, which is always a good framework to tick off when we're trying to structure those mental health care plans for people. So moving on to vaccination advice updates. So this may change depending on your location and depending what's funded free, what's not, what's able to be accessed easily. This is basically just a recommendation on the vaccinations that the diabetic patient should be having. So top of the list always is our influenza, and in Australia we're lucky enough in Queensland anyway, anyone can access a free flu needle every year. So influenza annually. Pertussis, so if the patient's over 65 and they've not had one in the previous 10 years, we want to be giving them a whooping cough vaccine. Hep B for travellers, the new shingles vaccine for ATSI people over 50, and the general population age 65 and over. That should be able to be provided to the patient. COVID-19, assess as per the current ATARGI advice. So most practitioners would be offering their flu needle with their COVID needle. This is just becoming, one and the other. Patients can make their choice. Pneumococcus is a little bit complicated because it has a few different recommendations there, and I would strongly recommend you look at the Australian Immunisation Handbook so that we get our strains correct and working out if we're giving a pneumococcal 13-valent, 23-valent, which one we're giving at what particular time. So I often find it's easy in this case to talk to our friendly practice nurse and find out, just see that they agree with what we think the patient should be having in terms of their pneumococcal vaccine. I don't think that you could do anything wrong if you gave a 13 instead of a 23 or vice versa, so long as that patient has been covered for pneumococcus. And also now we have a respiratory syncytial virus vaccine. It is recommended for adults aged over 60, however, is not funded, Queensland anyway, and I think it sits at around maybe $200. And the Arexvy, I think, is a two-needle course. So that tends to be out of people's range, but we are looking to see if that's going to be funded in the next few years. So preoperative medication advice. I know it seems we're skipping around, but it is a bit of a cook's tour through the handbook. So preoperative medication advice, especially including our SGLT2s and GLP-1RAs. So this generally may fall into the realm of the anaesthetist when they're doing preoperative medication. However, this covers things like minor major surgery, colonoscopies, endoscopies, anything where a patient has to fast. We need to consider these medications. So when a person is commenced on diabetic medication, it's always recommended that we inform them about the risks of DKA associated with clinical procedures, and ideally with written information management plans. In a perfect world, yes, we would be able to do that, but there are so many things to consider when we do start a person on a new medication that I can see that this would be fairly low on the list of priorities. Insulin may be required post-op for some people with diabetes. But as we've already sort of discussed, it will probably be the anaesthetist or the hospital surgeon that does manage all of this. But it's good for us to know what roughly should be happening and what their targets and their goals are, because the patient more often than not will come to us for our opinion to see if the hospital doctors are correct with what they're doing. So patients should be seen several weeks before the surgery for assessment of their diabetes, anaesthetic suitability, and any treatment modifications with medications. We're aiming for a HbA1c of 7%, and that's been shown to result in fewer complications, shorter hospital stays after surgery. If the HbA1c is greater than 9%, recommendations say that the surgery may need to be delayed. However, that would be anaesthetic surgeon's personal option or choice, depending on the necessity of the surgery, the patient's comorbidities, and also the effects of just delaying that surgery in general. So specifically with SGLT2s, the guidelines are recommended for temporary cessation prior to procedures as follows. For surgery and procedures requiring 1 or more 2 days in hospital, stop the SGLT2 for at least 3 days, and that may require increasing other glucose lowering drugs during that time. So that's where our metformin insulin may come into play. If it's part of a fixed dose combination, we might need to take 2 of those off. So the 2 medications, Jardiamet, something like that, that's in a medication. It may need to take that off and just leave the patient with some metformin for a while. So that brings us to the end of our significant updates. As I have said, it is a bit of a tour all the way through those topics, just touching on those things, and it is an update. So we'll go to our case study now, and we'll implement some of the things that we've learned from those guidelines and try and manage a typical patient with diabetes in the community. So we've got Stuart, who's a 43-year-old male. He's a new patient to our practice, married, 2 children, works in corporate sales, used to be fit when he was younger. His wife sent him in for a checkup after seeing something on TV about heart health. And that's how Stuart has come in to see the doctor. When we've said, how can we help you today? My wife told me to come in and get my heart checked. So typical presentation gives us a blank slate to start from. So what are we going to do with Stuart? We'll start with his history. He's a non-smoker. He drinks regularly with clients, footy mates, and with his family, social circle. We examine him. He's quite tall, 185, carrying a bit of weight, 130 kilos, BMI is 37.9. So that puts him into the obese category. Family history, mum with diabetes, breast cancer, dad has had an MI, and a couple of skin things taken off, skin cancers. So we look at Stuart, getting a picture of him, how we're going to examine him, do his heart check. He's already in a little bit of a danger zone there with his blood pressure being 140/65 and being obese, male. He's agreed to do some bloods for us. So we're going to send him off for basic bloods, full blood count, ELFTs, fasting lipids. And we're going to say to him as our targets for Stuart, what we would like him to do is work on his weight, and we would also like to work on reducing his alcohol intake in the long term. We don't want to frighten the horses, so to speak. So with Stuart, we're just going to keep things fairly casual and try and engage him with working on these few things, which should be manageable goals for him. So 2 weeks later, we see Stuart. He's come back in. He's got the results of his bloods, full blood count's fine. ELFTs show a surprisingly high glucose that we probably weren't expecting at 9.5. His lipids were 5.3, that's fasting, and his LDL is 3.35. Otherwise, everything was fairly uneventful and unremarkable. So what are we going to do with that? With Stuart and that family history, we should send him off to repeat those bloods, including a HbA1c and an oral glucose tolerance test. So that's the 2-hour test. We've asked him to do that. His wife has encouraged him to have that done. He has that done. HbA1c comes back at 8.8. So that confirms that we are diagnosing him with type 2 diabetes. Bit of a shock to Stuart, not really ready for that after coming in to get his heart checked. What are we going to do now with Stuart? How do we introduce him slowly to this diagnosis? We're going to address his glucose control. We're going to address his blood pressure control. So we're also going to manage his lipids. So these are the three dot points we're going to manage with Stuart. How are we going to do that at our first dose? Trying to encourage him and engage him with his healthcare diabetic diagnosis going forward. So 3 simple ways. I often find it's easier just to break things into very small chunks rather than overloading a patient. So that's why it's good to see a patient for a few times over a few weeks with this diagnosis or with any new diagnosis. But obviously there's a lot to get your head around with diabetes. So glucose control. Let's start Stuart on metformin at 500 milligrams. We're going to start low and go slow. Just see how he responds to that. We'll be looking out for the usual side effects, gastrointestinal upset with it, blood pressure, repeating the blood pressure readings in the clinics. He's still sitting around that 140/80. For his age group, we really want to get him down a bit lower, and we want to start low and go slow, ramp that up. So we'll be starting him on an ACE. For one of anything else, we'll just start him on some Ramipril, 5 milligrams. And he also needs a statin as well. So we're going to start him on Crestor, 5 milligrams. Any of the statins are fine. There's subtle differences between them. If you find that a patient can't tolerate one, it's easy enough just to swap a patient over to another and manipulate the dosing with that so that it is an acceptable management tool for them. Education. This is a big one that often gets overlooked in the diagnosis of a patient. I know we're all so rushed. It's easy just to say, there's your pills, there's your tablets, I'm going to see you in a couple of weeks, and off you go. Really important for a patient to be educated and aware of what diabetes is, what's available to them, why we are so worried about it in terms of long-term complications and implications for that patient. So it's always good to fill out an NDSS application. So that's the National Diabetic Support Scheme or Subsidy Scheme for a patient. We also like to refer a patient to a diabetic educator if you have one available through a GP management plan, and also refer the patient to Diabetes Australia. They can join up free. They get some promotional material through the mail a couple of times a year. And that's a really good little prompt just to give the patient small chunks to work through. So as I said, this may be done over a couple of appointments, just depending on how Stuart copes with that diagnosis. So what's our plan going to be now for Stuart? We're going to follow him up in 3 months' time. We've given him a PAC form to see, a pathology form to see how he goes, obviously with the disclaimer that if he's unsure about what's happening, we're going to review him earlier if he's having any concerns with his side effects. But we've sort of got him to this point now. We're saying, okay, we're happy with where you are now. I'm going to give you three months to see how you go on your medications, managing your lifestyle, working a little bit of exercise into your day, trying to get the alcohol down a little bit. So let's see how Stuart goes on his own after 3 months. So after 3 months, Stuart comes back to see us. We have managed to measure his HbA1c at 7.5. Not bad initially for 3 months. Fasting cholesterol's down. LDL is down a little bit, so getting that a bit better. Blood pressure looks like that's getting itself sorted out. Still not at target. His weight, he's only dropped a couple of kilos, but steady. It's only been 3 months, so we've only got him on metformin, and life often gets in the way of people, patients. So what do we think of these results? What would we do? What would we target with that? Any changes that we'll make? He hasn't had any side effects to any medications. So how will we manage Stuart going forward so that we can achieve the targets? As a reminder, we've got the medications at diagnosis: metformin 500, ramipril 5, Crestor 5. So what will we do with that? We can easily increase his metformin to twice a day. We can also increase his ramipril and Crestor. We're going to continue with his lifestyle interventions, support, encourage exercise. So depending on where we are in the yearly life cycle, we could swap that, use that GP management plan for some exercise physio, encourage him to get back into maybe some touch football or rugby with his mates, reducing the alcohol intake, looking at the triggers, meal changes. Is there anything that he has a lot of? Fizzy drink, snacks, flavored milks. Is there something that we can easily exclude from his diet that can give us another step towards reaching his target? So we're going to do the same again. We've made some adjustments to his medications, his lifestyle. We're going to follow him up in 3 months' time with another pathology test, see how he goes there. So 6 months later, we can see Stuart hasn't really shifted much with his HbA1c. Fasting cholesterol's come down a little bit more. Blood pressure, yep, that's come down a little bit more, as has his weight. So from diagnosis, he's down about 4 kilos. Still, that's at 6 months after diagnosis. So not anything great, but still, you know, we can work on that. So what do we think of those results? He's motivated, but unable to control his meals and weight, and he has reduced his alcohol. So they're all good indicators. What are our treatment options now with Stuart? So just as a reminder, we'll go back to see what his medication chart looks like. We've now got him on metformin, 500 BD, an increased ramipril and a Crestor. Now, there's a couple of different options. If we think back to our NDSS medication chart that we've got for managing this, there are any combination. that we could use for Stuart. So we've just used a demonstration one for tonight, and nothing would be wrong so long as we're heading in the right direction for Stuart. So he's able to access the semaglutide on PBS because his HbA1c is still greater than 7.5. So we can access that for him. He's happy to add this in. A weekly injection doesn't really bother him. We're using it for glucose control. And so now his medication is going to look like this on the right. We've got metformin. We're keeping the metformin, keeping the ramipril, Crestor, adding in the semaglutide. Now that is an escalating dose. So we start at the 0.25 milligrams per week, weaning up to, we'll eventually get him up to 1 milligram a week over the 4 weeks. We're also going to continue with weight loss management, diabetic, educated dietitian, exercise. And as we've said all the way through, the theme is the foundations is meals, healthy meal choices, and exercise. We're going to give Stuart his 3-month pathology form. He's getting fairly used to this now. He knows the drill. He can work this into his work day, work cycle. He knows to get his fasting blood test and then see us a week later in clinic, and then we'll have a look and see what he's managed to achieve. So we plan to see him in 3 months. It's taken Stuart 6 months to get back to us, which is fine. So he's out at 12 months now, post-diagnosis. So when we look at his medication and where we are with him, we've managed to get his HbA1c down to 6.5 in 12 months from 8.5. We have his fasting cholesterol at target at 4, LDL still okay at 3.0. Blood pressure, we've got down to 125 on 60, so that's fairly good. His weight, we've managed to get 10 kilos off in that 6 months. So that's quite a good achievement and quite a good picture. So what do we think of those results for Stuart now? What would we do with that? Would we change anything? I think you could continue to aggressively manage his weight. You'd want to also monitor his glucose going forward. Personally, I probably wouldn't change his medication at this stage. I would just leave him on the semaglutide. I'd like his weight to continue to decrease. I think the other indicators there, his HbA1c are fairly acceptable. Blood pressure is where it needs to be. I'd like his weight to be closer to a healthier BMI. So I'd be leaving Stuart there and seeing how he goes. So bringing us to our summary of tonight's talk. Diabetes is a chronic disease. The foundation is lifestyle, diet, and exercise. They're some of the things that we always manage every time we see the patient. Don't forget mental health, treatment options, multiple combinations. We need to think individually for the patient, what's acceptable for them, what's going to work, and we need to recruit them as partners in managing their diabetes, not something that we do to them or for them. It's their diabetes, not our diabetes, so we need to help them manage their diabetes with all of these tools that we have in our toolbox. So that's just some references. So yeah, just to have a look at if anyone wants to look at some further information. I'll throw back to you, Campbell, now, and we'll see if we've got any questions there, anything that's come out of our guided tour around diabetes tonight.
Wonderful. Well, thank you, Simone, for that insightful presentation. You certainly covered a lot of ground there. So as Simone said, let's now move on to our Q&A session. So we've got a few in already, Simone.
Mm-hmm.
And I don't know whether this might be outside the scope of this presentation, but something we were alluding to earlier before we came on. Hamali writes, what is the role of fish oil in HDL cholesterol?
Yes, it does have a role. It's limited in the recommendations. Statins still are our key medications. Patients can use a fish oil if they want to, but I don't think the evidence shows that it will achieve the target that we're looking to achieve for diabetic patients.
Right. On a slightly different tack, Aveline writes, how do you navigate the hypoglycemic agents where PBS limits the number of medications the patient can have on PBS?
That's very difficult. So PBS limits medications, especially with the semaglutide. So you have to be a little bit creative with what you use, what you do, and that comes back to sometimes combination medications. So Jardiamet, which has got metformin and Jardiance or dapagliflozin, empagliflozin in it as well. So that can be one medication. But often I'm not aware of anyone that's been audited because they've used too many diabetic medications for a patient on PBS. Often if they are sent to an endocrinologist, they will come back with a plethora of different medications, but there's quite a reasonable scope to use a number of diabetic medications for patients without sort of breaking any rules with the PBS.
Right. So a question just come in from Maria, which is quite interesting. And she asks, I just want to ask how we deal with patients refusing statins. I have patients who have preconceived ideas with statins and refuse. Can we offer, and apologies in advance, ezetimibe for these patients?
Ezetimibe, yes. Yes, yeah, valid question. And the poor statins have been kicked around a bit in the media. And just as a point, all of that negative, most of that negative media coverage has been disfounded or disbanded. Statins are still a really, really useful medication to manage cholesterol. Yes, they do have significant side effects. The side effects tend to be transitory. So if we stop that statin, we'll stop the side effect. There are some people that just do not respond to them and do not tolerate them. Those patients, yes, can have ezetimibe. And also, if you're concerned about those patients, I would be referring them early to either our cardiovascular colleagues or an endocrinologist to consider them having one of the other medications, the PCKs, and that's the injectable Repathas that they can have, because they actually can give us some really good results. They also have some side effects as well, but I do acknowledge the problems the bad press statins have had, and some patients generally can't tolerate them. And once again, you can really only do what you can do. And if the patient has that familial hypercholesterolemia, we do find ourselves in a difficult situation, and they'll probably be under specialist care anyway.
Fantastic. Now we've got a slightly, it might be outside the scope once again, but Pei Chen Lin writes, can you please briefly discuss with hypoglycemic sick day rules?
Yes. So if a patient, sick day rules basically means that a patient is either not eating or fasting. So we'd revert back, and that's, useful also for fasting periods such as Ramadan, things like that. There is a section, I believe, in the latest handbook to cover those sorts of things, those sorts of situations. So even though it hasn't made our slide tonight in terms of an update, that they've well covered in the handbooks, and we'd be pulling back their medications, especially things like the Jardiance, the empagliflozins, metformin. It won't hurt the patient to miss a day here or there of that if they're not having a full diet, or if they're fasting or getting ready for a colonoscopy or something like that. So that's fine.
Wonderful. Samaha writes, do we need to register all diabetes patients for NDSS, and why is it particularly important for type 2 diabetes?
We don't need to register all patients with NDSS. It is a free government initiative that gives the patient free or lower cost Lancet's access to, they get, I think it's a quarterly magazine or some promotional information on diets, meal choices. It also gives them ways to save money in terms of different chemists. Chemists are also aligned with it. So you might see that logo around certain chemists that support NDSS. And that just helps with the cost of things like Lancets, glucometers, sharps, things like that. So yeah, it's not imperative, but I find it really, really useful in building up that education base that the patient does have in the background going along. So yeah.
Excellent. And there was just a follow-up question from Pei Chen Lin. Where can we get the latest DM handbook?
Oh, as far as I know, it's actually not in print, it's online. So you'll see in the references there. So the very top reference, management of type 2 diabetics, and it's at the RACGP. You can get it there. As I said, I think it's 300 pages long. Download it as a PDF. I don't know if you can order or purchase a printed copy. But you can do your searches and all of that. And, you know, just for reference, the 2021 there is the Diabetic Australia one, which was the management. But the one we reviewed tonight is actually been endorsed by RACGP.
Excellent. At what point do we recommend bariatric surgery, especially gastric sleeve, to a type 2 DM patient who is morbidly obese, hypertensive, and has obstructive sleep apnea?
As soon as possible. Yes, in a patient like that, as soon as possible. For all of those comorbidities, weight loss is going to be just a life-changing event. The problem is accessing that. However, if the patient has that amount of comorbidities, hopefully they may be under a public specialist. As far as I know, in Queensland anyway, the only way to access public bariatric surgery is via a specialist. GPs can no longer refer to Queensland Health for bariatric surgery. The specialist has to do it. Sometimes you can prompt the specialist to do that by saying in your referral. And it is still done, but the numbers are so low that it's rare that a referral gets accepted. But for a patient of that comorbidity risk, as soon as possible, we basically need to get that weight off them. And it's obvious that lifestyle interventions are probably just not going to get us there.
Excellent. Thank you for that. So just a couple more here. How do patients access continuous glucose monitoring? Is it via GP or diabetes educator?
Diabetic educator. Interestingly, GPs are not registered or allowed to sign off on a patient accessing their CGM, their continuous glucose monitoring machine. It needs to be diabetic educator or an endocrinologist. So that's why basically it is type 1 diabetics or pregnant type 2 diabetics that have difficult to control diabetes that are able to access them.
Excellent. And one final question here, slightly on a different angle, quite interesting. Could you please talk about the commercial driving licensing assessment for type 2 diabetes with OHA or insulin used? Do we refer to the specialist for type 2 or who is on insulin for commercial driving assessment? I got a bit tongue-tied there. Did that all make sense?
It did make sense. I know exactly what you mean, Campbell. Yes. Now, driving is covered by the Australian road rules, the Australian driving guidelines. For type 2 diabetics with insulin, that use insulin, that are commercial, so anyone over an LR, in Queensland it's LR, which is a light rigid, so anyone over that, or that is like a commercial driver, so driving passengers around, they need to be assessed annually by their specialist. And I do, in my practice, I do have my little cheat sheet, because I always look back at this, because patients, for some reason, always think that we have got it wrong. So it's always good just to have that, and that's in the Australian Driving Handbook. There is a really great little algorithm that shows you patients that are on insulin, are not on insulin, whether they've got a private license or a commercial license, and it just follows that down. And yes, any patient who is on insulin with a commercial license will need to be managed by a specialist endocrinologist. And I'm pretty sure in Queensland anyway, that is one of the indicators for referral, like our smart referral system, is an insulin-dependent patient with a commercial license needs to have their annual assessment done publicly. So they can have that. They can also access it privately, which is nice and easy if they've got a private endocrinologist, but it is one of the ways they can access it publicly.
Wonderful. And that brings us to the conclusion of the webinar. Thanks again for all your insightful questions today. It's certainly been a very engaging discussion. A big thank you to Dr. Simone for taking time out of your busy schedule to share your expertise, and to everyone for joining us. And we hope to see you at the next webinar. Dr. Simone, thank you very much.